This is a work session. It's May 21st, 2020. Colleagues, thank you all for making time for today's discussion. Governor Brown's reopening framework asks counties to submit public health plans and get approval from the Oregon Health Authority and the governor before they're able to move towards their first phase of reopening. And just as a reminder, the highlights of phase one are that restaurants and bars will be able to offer sit-down services. Businesses like salons and gyms can reopen, and in-person gatherings of up to 25 people will be allowed. And just sort of on an interesting side note, the OLCC this morning has begun to publish their new rules that would allow restaurants and bars to potentially do expanded service outside to be able to make social distancing work. And when we combine that with some of the work that
the Transportation Bureau and Commissioner Udaley had been doing around closing streets, I think that provides some really exciting and innovative opportunities to not only help our restaurants and bars get through this crisis. I think it also lays the groundwork for some really great public spaces going forward. Of course, all of these new rules will still come as a major change for our community. And today I'm very happy to welcome leadership from Multnomah County Public Health, Dr. Jennifer Vines, and of course, the emergency management folks to brief us on their approach to meeting the governor's criteria. With us today, we have Public Health Director Rachel Banks. We have, of course, Tri-County Health Officer Dr. Jennifer Vines. We have the Communicable Disease Program Manager Kim Taves, and Emergency Manager Chris Boss, and of course, Chair Deborah Kafori. This is a great opportunity for us to learn about the plan and to ask whatever questions we might have. So I think we should ask questions as we go along and have a free-flowing conversation. I will do my level best to monitor the chat or the participant line. And so if I see people raising your hand, I'll do my level best to call on you. So with that, I will turn it over. Welcome and thank you all for being here. And of course, my notes don't say who I'm turning it over to. So I was sort of hoping somebody would jump in at that point.
Our Public Health Director, Rachel Banks, is going to be kicking it off.
Perfect. Thank you, Chair, for saving me. I appreciate that.
Good morning, everybody. And folks have the slides, or should I try to share screen?
We do not have your slides, so please share your screen. Thank you.
Give me a second to work through that. Because I don't have it up. Actually, Chris, any chance you have it up?
Yep, I will try to drive.
Okay, sweet. Thanks.
Give me a second.
So, good morning. It's a pleasure to be with you all today to be talking about reopening and our plans. So today we're planning to do three things. And just again, for the record, my name is Rachel Banks. I'm your Public Health Director, and I use she, her, and her pronouns. Next slide, please. So today we're going to be talking with you all, really wanting to give an overview of where we've been, most importantly, focusing on where we are today in terms of our public health response and reopening, and share with you the values and approach to reopening to the next phase. Next slide, please. So I thought I would start out with just talking about what public health does before a pandemic, which seems so long ago, but is still really important in how we are currently responding. So what you'll see here is a couple of different things. On your right-hand side, these are the drivers of health and health outcomes. And so you have things like, these are really environmental and social construction concepts, right? It's more about how we design society for folks than it is about their individual behaviors, and really understanding that people's individual behaviors are really guided by the choices that they have. So things like how we design our streets, the mayor was talking about ways to redesign and rethink about Portland so that people can engage in activities in a more safe way. That's really a perfect example of that. There is, of course, access to healthy foods and fruits and vegetables and all of those things. There's really the social context, the supports that people have around them, the experiences they have with justice, this where things like experiences with racism and discrimination play into poor health. You have education and opportunities for education in culturally appropriate ways. Of course, the piggy bank there, the economic realities for folks. And I raise these because these are drivers of good health and good times. And we know that all of these things have really decreased for many people in our society, these abilities to have these foundational health capacities. And then, of course, access to healthcare. What you have on your left-hand side is our 10 leading causes of death here in Multnomah County. These are really mirrored statewide and across the nation. You may see things in different orders, but the reason that this is important is because this is where we have the best chance to intervene and save the most years of life and quality of life. It's also where we see the most egregious health inequities. So there's no way for us to achieve health equity without focusing on these leading causes of death. In large buckets, they're chronic disease and injury, things like heart disease, stroke, cancer, as well as things like overdose, car crashes, and whatnot. So next slide. So those are all things that when we talk about underlying health conditions, they're important in COVID-19 because folks who have had disparities in those leading causes of death are at more risk for serious illness and death from COVID-19. This is just an overview. I don't expect folks to be able to see every single thing. It mirrors much of what I just said, but this is what a modernized public health system looks like. It has areas of focus, and it also has core competencies. So, of course, communicable disease, that is front and center for us right now. But within that, it's about having good policies, good community partnerships, strong leadership, assessment and epidemiology. So we know our data disaggregated by race and ethnicity, as well as, of course, leading with race and equity. Next slide. So before I turn it over to Chris Voss, all of those things are our ability to lead with race inclusively and before a pandemic also shows up in our response now. And so through our emergency operations, and these are our values that we hope you will see showing up, and we know that you have the same values, that we're going to lead inclusively with race in every part of our response and really dig down and create culturally specific strategies to protect folks who are at serious risk of illness, increased illness, and death. And so with that, I'll turn it over to Chris Voss, unless folks have any questions.
And I'm going to try and move quick because I know we have a bunch of slides, and I know you guys want to probably you might have some questions about sort of reopening, but we're still doing a lot of stuff. And even after we start to open, we're probably going to still be active for a while. And as you know, we have 4 congregate care shelters still open. We're providing over 18,000 meals a week. We've received over 600,000 items donated. We've over 4 million items we've received through resource management and distributed about over 3.2 million of those to hospitals and other community organizations. So there is a lot going on every day here in Multnomah County as we continue to manage our operations. And the last thing I say before we get sort of the dashboard stuff is that I think the most difficult aspect and where we spend a lot of time is actually connecting all of those pieces. So from the notification to the shelters to what we're doing with feeding and outreach, transportation, all of these things need to connect. And that's why we opened the EOC, went to enhanced level back at the end of January, God, it feels like years ago. And why we've continued to keep recently, I think our numbers we're probably hovering about 150 people a day working in the EOC. So that being said, I wanted to hit some of our dashboard items. And some of these, we changed our dashboard on Wednesday. So some of these are updated. If you have sort of an older briefing that we gave our commissioners on Tuesday, we updated some of these for Wednesday. But both our hospital, they are continuing to report. These are regional requirements for us to reopen. And I want to say the hospitals, both their PPE and they are reporting data. So both of these criteria are met. And you'll see us focus a little bit more on the ones that are probably not met. So I'll work pretty quick through these. Also, the county first responders, I want to thank the city, police and fire. They've provided us some information from them, as well as the other 10 organizations that are supporting first responders around the county. We have information from all of them, and we believe that our first responders have sufficient PPE based on the information they've provided us. And there's this one that we still have in progress. This is an added metric that we are using in the county because we think it's important not just for our hospitals and our first responders to have PPE, but there's a lot of community organizations out there as well, from TriMet to Meals on Wheels to home health care, nursing homes, all of those organizations. We do receive supplies, and we do help provide them with PPE when they cannot receive it through the normal supply chain. And so what this is really a metric about is the normal supply chain in a situation where it's able to provide all of those groups. And if it's not able to provide those groups, there are groups that reach out to us and say, hey, we need.
One moment. Commissioner Hardesty had a question. She wanted to jump in here if she could.
Thank you, Mayor. Thank you, Chris. My question was around the PPE and whether or not we have sufficient supply. Are you only talking about PPE as it relates to healthcare providers?
Yeah, so great example, and I can go through one or two slides, but the state had the two requirements. One was for hospitals, one was for just first responders. We created a third one to address all of those other organizations that needed to support, like I said, home health care, Meals on Wheels, TriMet, all of these other organizations that might need it. And so
shelter workers.
This slide right now, you can see these are the asks that are coming into the county from other organizations that might need it. And you can see we've been pretty steady for the last 2 weeks, where we are still getting these requests from organizations. To give you an understanding of what some of those organizations or who they represent, I've got sort of one or two slides. You can see this is the week of 5/4 through 5/10. You can see healthcare providers are the largest group, but congregate housing settings, that's second largest. Organizations serving communities of color, 13 requests during the course this week. And so you can see we track not just first responder and hospitals, but also these other organizations. There's this group, and then here's the following week. You can see the sort of subtle changes. The numbers in total are about the same, but you can see healthcare providers, because now more of those are up and running. We're getting some more requests. Ideally, what we'd like to see is fewer of these requests coming in, because all of these organizations, with the exception of hospitals and first responders, all of these other organizations have to attest to basically saying they've tried to actually receive PPE through the normal supply chain, they were unable to get it, and they have less than a week's supply. And then that's when they come to us, and then that's when we say, okay, if you meet our criteria, we're gonna help you out. So that was the big picture on PPE, and I don't know if Rachel or Kim, if you wanna take this next dashboard update.
Thank you, Chris.
Sure. So one of the reopening criteria is having isolation facilities. And as you know, we've been working on a variety of sheltering strategies, from social distancing shelters to medical motels and all of that. So we have hotel rooms and shelter locations for people who cannot self-quarantine. Another requirement was for us to provide a narrative of how we would respond to 3 out of 4 outbreak scenarios. We decided to go ahead and prepare those narratives for all 4 of the scenarios, and those are shelters, food processing plants, long-term care facilities, and corrections. And so we've uploaded those narratives onto our dashboard as well. Next slide, please, Chris. So the next slide should be showing our available, I believe. Chris, can you forward it one more? Actually, back a couple. Okay, forward one. All right. So this is talking about the percentage of emergency room visits needing to go down. And there's a couple of things here. One is the percentage of emergency department visits for COVID-19 like symptoms being less this time of the year than it was last year for the flu season at the same time of year. So we have that hospitalizations are down across the board. That is met. There also needs to be a 14-day decline, specifically in COVID-19 hospital admissions. Once again, that is down. But when we put out the dashboard, we also wanted to add criteria, Multnomah County specific criteria, to understand the impact of COVID-19 on communities of color, realizing that it would have been possible with our demographics to have a 14-day decline in hospital admissions overall, but see an increase for Black, Indigenous, and other people of color. So we added a metric around needing to also see a 14-day decline, or see that decline for the BIPOC communities. And we reported yesterday that we met that threshold. And the next slide, I'll show you what the BIPOC hospitalizations look like. So this is new information released yesterday, and I'm going to go through the colors just in case it shows up funny on different people's computers. But the top bar here is other or multiracial. That's a turquoise. The orange underneath that is Native Hawaiian or Pacific Islander. The green is Hispanic and Latino. Underneath that is Black and yellow. You have Asian in red. And then at the bottom, which you'll just see for the week of March 29th, is American Indian or Alaskan Native. So you can see that hospitalizations are going down across the board. And also when we look at each specific race and ethnicity, they're also going down. Next slide, please. So healthcare capacity. This is a regional measure, and we need to ensure that that there's healthcare capacity and that the hospital systems can accommodate a 20% increase in hospitalizations. And I guess, I should have said up top that we fully anticipate as physical distancing loosens, and as we move into phase 1 and more people are interacting, that there's more opportunity to spread the virus from person to person, and that we will see cases going up. And really the goal is to open in a way that we are able to have sufficient healthcare capacity for everyone to be seen and not end up in that surge capacity that we all wanted to desperately avoid with these physical distancing measures. Next slide. So contact tracing, the hot topic. There's a number of metrics here that the state put forward, and then we have increased measures for us that really get at health equity. So we needed to have, the state's put out a ratio of 15 contact tracers per 100,000 people. Countywide, that gets us to about 122 people that we would need based on our population. Kim Taves, the communicable disease director, is going to talk to you more about the model that we have, which is not just about having people in seats, but it's also about working with community-based organizations, and it's also about having a robust wraparound support so that folks can afford and can eat and survive if they're staying home for 14 days if they've been in contact. However, so toward the measure of the 122 people, we have 36% of folks hired. We've been rapidly increasing this, and are working every day to get more folks on board. The state's requirement is that the contact tracing workforce is reflective of the county and able to work in needed languages. But we really have wanted to go above and beyond. And actually, I shouldn't even say above and beyond. It's just what's actually needed for health equity, which is not just about having a diverse workforce that matches the county's demographic, but it's also taking into consideration that we are seeing disparities in COVID-19 for certain communities. So and that those underlying health conditions that I talked about earlier on, that those are disproportionately impacting people of specifically Black and Indigenous folks. So we want our contact tracing workforce to really match what we're seeing in terms of this current disease and what we may anticipate based on those past health injustices. So for example, if we're talking about the Latinx population, where we could say, 12 or 13% is about what we would need. But when we're looking at 30% of the cases, then we need a much higher percentage of folks that have that language and cultural capacity. So we're working on that really with a focus on getting our language specific folks in first, as well as our cultural KSA, what we call KSAs, so knowledge, skills, and abilities. The last one is that we're prepared to trace 95% of all new cases within 24 hours. So last week we were showing about 60%. We've identified that there were some glitches with how the state was capturing this data, and now we are at 80%. And this is one of the measures that will let us know when we're ready to move to the next phase. The state has said we don't have to have all of those 122 people in place to move into the next phase, but we need to be able to trace people with them. The majority of folks get to them in the first day. Next slide. And with that, I will turn it, unless there's questions, I'll pause for questions and then turn it over to Kim Taves.
Thank you, Rachel. Commissioner Hardesty has a question.
Thank you, Mayor. Thank you, Rachel. My question has to do with the contract tracers. and the numbers that you say you will need. I think I've asked this question before, but I have not received a clear answer. And the question is, can these people be from the community? Can contract tracers be people who already are embedded in the community and aren't government employees? I think there were 3 levels that we talked about. Some have to have a medical background. Could you talk a bit about who tracers are and where they will be employed?
Yeah, I'll give an answer and then let Kim delve down into that. So yes, they absolutely can be in the community. And in fact, we know that is where many trusted employees are. They're working in community-based organizations. They're already community health workers or case managers or navigators or family advocates. They're called a variety of different things in different organizations, but absolutely they can be. And so the reason for us having a variety of levels, there is a need to have folks that do work in those government positions, and we are making sure that our expanded capacity there is diverse and linguistically specific, but then also having folks in the community. And so there's 3 different sort of things that happen. One is the initial case investigator who gets the lab result and follows up with the person, the contact, and then they're identifying contacts. And so the contact tracers are folks who would then follow up with the contacts. Our model's more integrated than just having a separate person go follow up on contacts, and Kim could talk about that. But the specific answer is yes, they can be in the community. Not everybody needs that medical background, but we do need to have a model where folks who are in the community can be connected to people who do have the medical background so that we're making sure our communities are getting the best information.
And the last question, have you considered utilizing Portland Fire and Rescue? You do know we have EMSs that have the medical background and expertise and also deep community relationships. So I hope we're going to think creatively about whether we hire people or whether we use resources that we have. Thank you.
Yeah, thank you. And I think another kind of thing, we'll talk about testing as well, but thinking about fire and the EMS, as you've talked about, testing is another place where I think that partnership can be really valuable.
Commissioner Udaley has a question. Unmute, Chloe.
There we go. First of all, I want to really appreciate the focus on equity that you're bringing to this conversation, and especially the nuance around the metrics. And I hope that we share back to the state, because they're obviously lacking that nuance currently. My one concern, and it's always my concern, while I absolutely agree with focusing on racial equity and disparate impacts, I haven't heard anything about people with disabilities. And we know that people with disabilities are especially vulnerable. They're more likely to be low income, more likely to be housing insecure, more likely to be in that digital divide. And for some, they are more susceptible to this illness and more likely to die from it. So I'm wondering if there's been any special consideration for that population, regardless of race.
Yeah, thank you for that. And Kim Chase is going to talk more about, because I think you're getting to the point of what is leading inclusively with race, which is not totally with race, but is leading inclusively. And so there are additional culturally specific populations and positions that we have thought about that aren't just the race and cultural ones. So thank you for that great question.
Fantastic, thank you.
So I'm going to dive a little bit deeper into the Multnomah County contact tracing system, and this will help, I think, flesh out a little bit more of what Commissioner Hardesty is asking. First of all, my name is Kim Taves, and I am the Communicable Disease Director for the County Health Department. The contact tracing system that we've envisioned has 3 different components, and I will give you a more detailed, messy, complicated graph in a second that shows you how the workflow works. But basically, there is a team, a subset of this system that is community-based. This is what Rachel mentioned through subcontracts with culturally specific community-based organizations. Could be navigators, family advocates, case managers, caseworkers, community health workers is the model from public health that we're most familiar with, but there are a number of different names for folks who are very familiar with the culturally specific communities, as well as familiar with which social service and food scarcity and housing and rental employment assistance opportunities there are to help folks with their basic levels of survival that they need. And then we will overlay on that training, if they don't have it, with sharing basic health education and health promotion messaging around this disease specifically, so that they can be a backup to the initial conversation that public health has with people as we try to explain to people, what does it mean that you just tested positive? What does it mean that you've been exposed or what we're calling a close contact to a case? So the goal there is that we've got those folks from community, embedded with community, that are already working in organizations that community knows and trusts for seeking help and support. And then we also have the public health case investigation team. And this is case investigation / contact tracers. That word got picked up by national media and came out in some of the guidance or recommendation, but it's actually a whole complex set of folks with a lot of different skill sets that make up that system. And then we also have the third, probably most technical part of our system, which is the outbreak response team and our epidemiologists. So Chris, if you can go to the next slide, we'll delve a little bit deeper into the goals and then into how that workflow works. So the goals with this part of public health, and this is an intervention that we've done for decades and decades, and we've done it across many different reportable diseases, whether it's a restaurant that seems to have a locus of foodborne illness, or it's community transmission of HIV, or it's tuberculosis that's being transmitted in a work site or congregate setting. This is sort of a core public health work for communicable disease, specifically infectious disease. So the goal is to identify and interview the people themselves who have the illness. I would have said previously the sick people, but we now know that there are some people who are infectious who don't have symptoms either. And we gather medical and demographic information that we need to help make sure that they're clinically connected, but also to give us a sense of epidemiology. And what that means is the patterns of disease transmission and the risks associated with those across populations. The next goal in that interview is to identify contacts. And those are folks who may be incubating the illness right now, but not know that they have it. And that can also identify some outbreak settings. And then it's to provide necessary support. So they just mentioned that the community health worker component can provide more in-depth. And all of that overarching goal is to contain the outbreak and prevent spread. So if we go to the next slide, which is sort of our complicated picture of that, it's sort of a multitude of steps, and we'll start on the left side and move to the right. So the case report, and this is really, I'm just going to go into this detail because there's so much mystery about what exactly this is, and then you'll understand why we need the mix of folks we do to check the checkbox for opening. The case report comes in from a healthcare provider or from a laboratory system, and it's most often comes in from the lab and is automated, and it comes into the state's reportable disease database. And that is a local health department / state co-owned data system that we've got real-time access to. So when that case report comes in, the case investigation team that sits in public health reaches out to gather some medical record information, make sure that that person is able to be interviewed. Some of the folks are hospitalized and they're not even able to be interviewed at that point, so we would interview a family member instead. But the goal is to interview the actual person who's got that diagnosis within 24 hours of receiving the case report. The first step is to collect medical and demographic data for them. That's where some of our race and ethnicity data has that level of detail, as well as language, et cetera. We use the Real D set of demographic identification that really came from community and then got adopted by the state for reportable disease, as well as other health data. And that goes into our secure confidential data system where the case report lives. And when the EPI team, I'll get to that in a second, they can use that to make analytic guidance for all of us about what's happening at the population level. The other component of that interview is to identify these close contacts. They may be household contacts or shared living quarters. They may be contacts if someone has sought healthcare while they were sick, or if they do work in healthcare. And they may also be contacts through other work sites. So the idea is that we need to know if they are social interaction contacts or household or family contacts, or if they're contacts that may actually show us that there's a setting where a lot of transmission is happening that we would call an outbreak setting.
Kim, I'm sorry to interrupt for a moment.
Yes, please.
Commissioner Udaly, did you have your hand up, or is that just residual? No worries. Okay. Sorry, Kim, go ahead. Actually, Kim, could I ask you a question on the, and thank you for this chart. And I think this gives us all sort of a sense of how complicated this is. What sounds pretty simple on its face is actually extremely complicated when you start pulling the system apart, what actually has to happen. As I'm watching this, I'm realizing that contact tracers need a great deal of actual specialized experience.
Yeah.
And maybe at the end of this report, you could tell us a little bit more. If I heard the previous presentation correctly, it sounds like we have not been aggressively hiring contact tracers lately. Maybe I've got that completely wrong, but at the end, maybe you could talk a little bit more about how you're connecting people to this skill set that's required.
Yes, happy to talk about that.
Thanks, Kim.
So the other component, besides asking the person some demographic information, identifying contacts, the folks do a first round of health information with the person, describing what isolation is when someone's infectious, and what exactly our expectation is of them to sort of step out of the work site, step out of the educational environment, step out of social interaction, and stay at home and isolate themselves for that time that they're infectious. We can go so far with that, but we found with this and with other diseases, and a lot of our model that we're using is actually a model that we use for tuberculosis treatment, which can be extensive, and in the United States ends up being primarily among folks who are arriving with TB from other countries or who are getting it in the homeless community. So people need, again, they are similarly some really specialized, culturally specific and language specific skills, as well as the technical skills. So that's what we've based our wraparound model on, with success we've had there. This is just as a much larger scale. So then we link folks that have the positive test results to community health workers that we've talked a little bit about already, to be able to work with that person and with their household or family. It may be a week, it may be a couple phone conversations. As a disease moves through a household, it may actually be like 4 to 6 weeks that we're trying to support a whole set of folks to isolate and get what they need to be able to do that successfully. That's really important for folks to feel like we are not just trying to extract information from them as government, and we're not just trying to isolate them from the income they need and the social contacts and supports that they need, but we're trying to recognize that, especially for folks who don't have a whole lot of safety net, this is a huge impact. And if they're going to do their part to help reduce transmission, they're going to need a lot of support and holding from folks that they know and trust to really to be in their personal business, frankly. Our relationships with community are incredibly crucial because this is voluntary information that people give us. We don't compel them. And frankly, there are some ways that we have capacity to use our public health legal authority to quarantine or isolate, but the process that we have to go through takes a number of days to do that. And that may be important to be used, rare case example, for someone with TB once in a blue moon. But the speed at which this disease travels and is infectious, we really need up front to just be very collaborative with folks. So that's where the full skill set of interviewing and establishing rapport with people and assuring folks that we're confidential and helping folks feel like they're collaborative partners in the health of the community takes a high level of skill. Our staff usually get training in motivational interviewing, which is a counseling technique that actually comes from addictions treatment world, as well as the medical background and knowledge. So there's a lot of different pieces. A lot of those folks don't have to have medical background, but they need to have a lot of community engagement, community rapport. Outreach skills are just as important. So let me move across a little. Oh, Mayor Wheeler, you look like you're about to ask a question or say something.
No, it's just I got a pop-up on my screen saying if I don't enter a code, I'm going to be logged off. I love our technology.
Great.
Fortunately, I have it. Never mind. So. Okay.
So let's look at what's the next step after that interview happens. At the top, we've got all this data in the data system, and we've got an epidemiology team. And that's the team who's created our regional data dashboard, analyzes the data to look at that more like community level about who and the how and the where of transmission to help us focus resources and other public health interventions. Once we've identified the contacts, we will ask them, and we'll ask the person who has the positive test result as well, where do you work? What kind of connections do you have at work? You know, what's your employment environment like? Where are you living? And the goal there is to identify if there's an outbreak going on. So that's where we have an outbreak team. And we'll end up with 2 different outbreak teams. Those are probably our most technically specialized folks. Those would be working in a long-term care facility, in a corrections setting. We have a couple outbreaks happening in other work sites that have folks that are providing essential service that need to work in close quarters with each other. That's where we work with healthcare, infection control folks. That setting has a lot of vulnerable people in it, as well as a lot of close contact. So their job needs to have more nurses on staff, more infection control specialists, and they're working more with agencies and employers. They'd be working, if we did have a shelter outbreak in a homeless shelter, which we've been very lucky, and as well as I think we've been very strategic about trying to avoid that with all the resources we've put in allowing that physical distancing changes to happen in our shelter system. But if we did, then we would send that team in to work really intensively with that whole area. The contacts that are identified, they also need to quarantine. Isolate and quarantine basically mean the same thing. It's just a semantic difference. They both mean if you're infectious or you could possibly be infectious, not being in contact with anyone else that you could transmit the virus to. So those folks need also that same referral to the community health worker team to help figure out how are you going to step out of employment for a couple weeks. Can you access unemployment? Do you need some rent assistance to be willing and able to do that? Those folks need some extra motivation because they don't for sure have the infection. We just think that they are at higher risk for having the infection right then from the contact that they've had. And just so you all know, the contact that counts right now is making someone a close contact is 15 minutes or more of exposure within 6 feet of an infectious person. So that's a pretty low bar right now if it's 15 minutes only. And we're casting that broader net. As of like a month ago, it was an hour. But you understand that the guidance that we all have about 6 feet apart is because that's how far we feel like droplets can travel through the air before they just settle out. So that is really, truly what we think like the danger zone is. And beyond that is probably fine as long as folks are also like washing their hands, because we know that those droplets can land on surfaces, stay alive for a few hours. And if someone touches them and rubs their eyes or their nose, then it can also be a source of transmission. So
Thank you.
when you have folks moving into go ahead.
I'm sorry, Commissioner Hardesty had a question on that point.
Great.
Thank you, Mayor, and thank you. This is absolutely fascinating information, but I want to make it more personal. So let's say that I have been exposed to COVID-19. A contact tracer contacts me. I'm a Black woman in America. And so somebody knocks on my door or calls me and they want all my business. Who have you talked to? Where have you hung out? How long were you here, there, and other places? Traditionally, I'm not prone to give that information to government who comes seeking it, right? And I also work for an employer that if I don't show up, I don't eat, I don't get paid. So walk me through how I would experience your contact tracers if all of a sudden they showed up at my door.
So we are trying not to show up at people's doors these days, especially. That's always been our last attempt to find someone after we try texting, phone calls, other connection points that we have. It's a lot of that rapport building is really explaining, here's what we do, here's why we do it, it is voluntary, and how we're going to partner with folks in a way that they still stay empowered about the information that they're sharing with us, and that we're partnering with them You know, my background, my initial foray into this whole field of infectious disease was in STD and HIV work. So same history of who's at higher risk for it, what some of the concerns are about that level of privacy of that kind of really personal information, and what the risks might be to sharing that information. So I think we work really carefully with folks to say, we want to partner with you and let other folks know, because we know that you care about your own health and you care about their health as well. It's the intention there is to express that top on our list of priorities is not to gather info from them that we put in a data system, but top on the list of our priorities is actually to help them make sure that they've got their questions answered, that they know where they can access health resources for themselves if they become more seriously ill with the illness. You know, we're trying to share with the employers that when the employers stand up testing, they can't just text someone the results from the HR team, right? They need anyone who gets these test results. It's pretty emotional right now, and we've seen every aspect of our work takes a lot of that kind of calm care and reassurance before people even are in a place where they can give information or take any information in a way that's meaningful. And frankly, I've seen this with the employees that we have that are doing the response work, just as well as with the community members with whom we're interacting. We're all in that state right now. So I think that there's an incredible amount of empathy that's really important for folks to be expressing, particularly right now. But the goals there are to work with someone to really identify with them, you know, what's your plan of action? What would be the barriers and the obstacles? What are different ways we can support and assist you? And that's where some of the funding that we all need to have in the budget to actually be able to give folks like super low barrier and really fast, easy access to dropping off food boxes, to bringing disinfectant products to somebody's house. If we're asking them to isolate, we're asking them to not take the bus to the grocery store, right? So what are the supports that they're going to need? And how can we use our community partnerships with the folks who already do that kind of work with people to be safe partners to actually come to their house and, you know, set stuff on the doorstep, stand back at the sidewalk, text them, I'm here, I've left your stuff, come up to the door. I'm happy to answer questions. I'm staying 6 feet away from you. It's the crazy way that we're all trying to do the work right now. I think there's ways to do it that are connected, but that helps you all understand how the idea that we'll just hire a bunch of telemarketers and give them a 6-hour online training and throw them into this work is really not going to be an adequate way to staff the work.
Kim, Commissioner Fritz has a question.
Thank you, Mayor. I was just wondering what happens to the data? How long is it kept?
This data is not deleted. It's kept in the state reportable disease surveillance database. It's got a higher level of legal protection around its privacy than regular medical health data does. It's outside of the realm of HIPAA, and it's in the realm of public health, Oregon public health statute. So it's quite protected. And it's kept indefinitely.
Thank you.
And is that all the information that you gather? So the people I talked to, the people I hung out with, what stores I went to, all that information is going to be in a database somewhere forever?
Yeah, that information is in the case notes part of the data system. So that information is there. If someone pulls up that record and looks at the case notes, some of that more demographic information, what date someone tested, the site, et cetera, is in fields that we can pull out and analyze to look at patterns. But that more detailed information we do keep in that database in the case notes. That's the same for all the reportable diseases that we have.
I'm troubled by that because a database will be created of people who have tested negative as well because they have had contact with someone who tested positive.
So the majority of the data that's in the reportable disease database is positive tests because the state has set up law, and all the states have this, and CDC guidance also requires us to give them data that doesn't have any identification on it and is much more simple data, but that's so that there's a national picture of epidemiology. Some couple diseases have the negative test data as well. HIV is one of, has been one of those, and that just was numerically reported. But this disease, because the state knew that we needed to be able to look at how many tests were done overall, what percentage were positive, the negative test data that is sent, we don't interview those people. And so it does have name, it has date of birth, it has gender. A frustration for us has been that we actually have needed it to be better about having race and ethnicity, because we need to show that the people tested are the right people to be tested and that there's not inequitable access to testing. Right. The way that we know that is by actually gathering data and looking at the data and seeing, oh, if we do have enough data in there about race and ethnicity, we can show that there's really disproportionate, inequitable access to testing. And then we need to fix that system of testing with public health and hospital systems and safety net clinics. The way we know that is from having public health data.
So we're collecting all the data except the race and ethnicity data?
That race and ethnicity data about a month and a half ago was about 40 to 50% absent. And now we've got about 75% of that. So the data for the negative tests is identified, but it's pretty simple, straightforward data that's name, date of birth, gender, race, ethnicity, and the provider that ordered the test. Yeah. So let me pop over to the next slide.
Before you do that, Kim, I just want to make sure. Commissioner Fritz, did you have your hand raised again?
I'm sorry, no, I forgot to put it down.
No worries. Thanks. Go ahead, Kim.
This is complicated, but I just wanted to show folks the steps we've taken so far for hiring so we can check the green box and where we're at on that for the reopening. So we started out with 3 community health nurses on the left side at the bottom and 4 epidemiologists on the team before COVID-19. And they were handling hundreds and hundreds of all the different reportable diseases. That's everything from measles to salmonella to tuberculosis. We pulled from our STD HIV team and some other public health staff at first from environmental health. Then the next step we did to bring on more folks as our case count increased was we added medical students and graduate public health students as their practicums and their preceptorships and their school classes went on pause, then they were available to us. Then we started to add on-call epidemiology folks and community health nurses needing that technical skill set. And then we worked to identify this future state model that I've just talked through with you all that has these 3 different teams and they've all got overlapping skill sets. And the numbers of folks that we were looking for, as well as what Rachel mentioned, that KSA, which stands for knowledge, skills, and abilities. And it's either culturally specific skills and experience or language skills and experience that we needed to have, as well as the technical skills in the mix in our team. And so where we've been recently is going through that union and HR process to establish positions and have hiring models. At the same time, we've been developing the model for the contracted part with community health workers and the CBOs. And so where we're at now which is the big blue bar in the middle, we've got 14 full-time staff. This is probably actually out of date already because it's about 48 hours old and we're hiring pretty rapidly. We've got 36 part-time staff and we've got at least a first subset of CBOs identified and a plan to identify and engage with others to start the contracting process. We'll be looking next at redeploying any internal county positions that already have language-specific skills or culturally specific skills attached. And we'll start hiring and training them, and then we'll post externally for new positions if we need those. Meanwhile, our community-based organizations will be hiring the community health workers or redeploying theirs, and we'll be supporting them in the training. The goal ultimately is to have that full set of staff in place. We're looking at doing this work for at least a year. Full-time dedicated staff that are really thoroughly trained. As that happens, we will be able to release some of the students. Hopefully by then school will be starting for them again, on-call staff, and then we'll have that ongoing set of staff. We don't need to get to that full staffed steady state in order to check the box. I think where we're at is we're getting there with the numbers and we've got strong technical skills and we're working fast right now to develop enough of the language capacity and the culturally specific folks that we need to feel like we've got that right mix of all of those skills for a set, and then we'll be modularly sort of scaling up, bringing on new teams that have that same mix of folks. We just don't want to be heavy in one skill set and not enough of the other right now. So we're getting close, but we're not quite there yet. I did want to talk about testing for a minute, but I'm happy to keep answering questions if you need about the contact tracing, because I know that that is a big focus of a lot of questions for the community. Okay, so testing capacity, we have met the capacity overall as a region, and I want to say the region is 6 counties, and we is not public health, we is the hospital, healthcare, outpatient, the whole system. All the commercial laboratories and hospital laboratories have attested that we have met the amount of capacity that the state wants us to have. We are currently doing testing larger than the capacity that we were required to demonstrate, and we haven't maxed out yet the lab capacity to do more testing. We have a requirement, and this is the governor's requirement. It says sufficient testing sites accessible to underserved communities. It's not defined for us more than that. We can define it for ourselves. And we feel like in our county, we have done great improvements on that in the last month. The hospitals were able to stand up a fair bit of capacity for testing in the last 2 months, but that wasn't necessarily across the board with our safety net and our community health clinics. Those folks were lacking more of the PPE, more of just the supplies for testing, like the swabs we need and the tubes for collecting the testing specimens. The labs came on board and we're having troubles at first having enough of the chemical reagents to run the tests. So the whole system has been like whack-a-mole in terms of we have enough of this, but not enough of that. We have enough of this, but these folks don't have enough of that. And folks have needed to really coordinate and share supplies and share referrals. The hospital systems have needed to say, okay, we'll partner with you, safety net clinics. So if you have your patients and you do the visit with them, you can send them to our drive-through testing instead of having to stand up your own testing. I think that's all had a lot of improvements just in the last 3 weeks-ish, I'd say 3 to 4 weeks, so that there's more equity in terms of the actual healthcare settings being able to provide testing. But we still got a chunk of folks who don't have a regular medical home, don't have health coverage right now, and or don't trust the system of testing, but when they get sick then do realize that they actually do want that testing but don't have a real low barrier pathway in. So we're doing some work right now with a couple different models to have public health in partnership with others stand up some more of the testing to fill some of those gaps. OHSU right now has drive-through testing at the Expo Center, which I would basically say meets some of those criteria for community-based, which means that you don't have to have a regular healthcare provider refer you. You won't be turned away regardless of your insurance coverage or ability to pay. It's got evening hours, it's got some weekend hours, et cetera. We don't have good geographic distribution of that across the county, so we're looking at what can we help fill in Mid-County and East County, so that there's some access points that aren't just in one spot of the county. And then we've also really heard very clearly from a lot of the communities of color, especially where folks have some different barriers to accessing healthcare from the mainstream healthcare setting, as well as really wanting to feel safe and comfortable to have other points of access for testing that maybe aren't just clinic-based, but are facilitated or collaborated with community partner organizations that are known and familiar to them. So we've been convening groups of meetings with folks to sort of identify what possibilities are that are culturally specific for each community and how we can help work to stand those up. So I think we'll have a minimum threshold of that we need to meet to check the green mark. But moving forward, I know that through the summer, we'll be doing that work sort of more intensively and comprehensively along the way to really fully build that out. I think that's where some of the partnerships with the hospital systems are important. They've got some resources that they can contribute. I think that's like a key place when we met with Portland Fire and Rescue to talk about where do you all have staffing, in the redundancy that you need to have available for fire response. But that means that sometimes folks do have free time and you have folks who are medically trained as EMTs. And so we're looking at a proposal that they've sent to us in terms of bringing on some of that EMT staffing for some of those stand-up drive-through low barrier clinic sites as a possibility. So I think that'll be a good collaboration. We've got a variety of folks to partner with in that realm. That was a great conversation to see and a great possible collaborative partnership that we can have to just spread across efficiency as well as utilizing the infrastructures that we all already have that maybe are available to bring to the table. I'll leave you with this, but I've already sort of verbally gone through a lot of it in terms of what our current state is, assessing it, some of the gaps I talked about. I think I forgot this slide was in the deck, so I already ran through pretty much the different public health projects. A piece I will mention is that healthcare needs to continue to keep their testing available. And right now they've started to focus a lot of the testing on people who are coming in for elective procedures and surgeries that just came on board May 1st. We need them to keep sustaining the testing priorities for symptomatic folks. And employers really need to continue to learn that they've got a role in testing. We may see some state guidance come out as there's been local and state advocacy and national guidance coming out saying long-term care facilities especially should probably be testing employees regularly so that they don't bring that infection into long-term care facilities. Healthcare has already been, as an employer in hospitals, testing their employees across the board pretty regularly. But other employers that are essential service providers that have folks that maybe do need to work closely to each other or in large group settings, we saw Amazon do some of that screening testing. This is not really outbreak response testing. It's the screening testing that we would use to identify if anyone was infectious. And early on, we really relied on people with symptoms, but now that we know, we've got to test some folks who don't have symptoms as well. So the goals are that equitable access, testing people with symptoms, screening in the high-risk settings. And we may need to see as well some testing of contacts. And we don't have recommendations about that yet. But again, healthcare would need to be able to participate with public health so that the folks who do have Kaiser can utilize Kaiser for the testing they need, and that there's some agreement among all of us about what those current recommendations are. So I will stop with that.
Very good. Thank you for that presentation. That was thorough. Any questions, colleagues?
All right. So thank you, Kim, for going over in detail what the
Commissioner Daly had a question. Sorry, Rachel.
Yeah. Sorry, Mayor. I was rushing for the mute button. I just need a little bit of clarity on how we handle contacts of someone has tested positive. Do they get tested, and is isolation enough to contain the risk of a close contact who doesn't have symptoms becoming a vector?
So the contacts, currently, we do not do routine testing on the contacts, but Dr. Vines and I are working with some of our retired public health experts that are around and willing to contribute their thinking to some modeling of, could it help us test contacts immediately to be able to do that next level of contact tracing for their contacts? Would that be able to help interrupt the disease transmission before, by the time you reach someone, if they've already had contact with 3 to 4 to 5 different sets of people, then our intervention is not nearly as effective, right? So there's a rapid response that's important. But we also know that with the barrier to try to have somebody self-quarantine who doesn't feel sick and isn't necessarily sure that they have the disease yet, that's a huge ask of folks. And so we've been looking at, is there a way that contact testing might help us release someone from quarantine earlier so that their family has less of that impact on them financially? So those are some of the things we're exploring. Some folks in the community have said, if I live in a large multi-generational household, I don't have my own bedroom. So if I'm sick, I'm really concerned about my other family and household members. Can you guys help us with any resources? I would rather just stay in a motel for 7 days and work this out of my system and not put my household family at risk of exposure. Sometimes by the time we know that they're sick, the family probably has already been fully exposed. But that's something that just like we have made that available for unhoused people that are in our shelters, that we need a medical motel, basically. That's one of the things that we're looking at to help with isolation as well. We'll need to do that kind of isolation if the exposed contact is already living in a residential congregate setting. Then those are really unique environments that we would work with to help them figure out how to do that isolation.
Okay. And then I have a couple questions about workers in specific industries and also safety of workers as we reopen, but I'm not sure. I don't have an overview of this presentation, so I don't know if we're going to be getting more into those specifics. Because
We've got one last slide here that I think Rachel is going to talk a little bit about some of the costs for this, but Dr. Vines is on our webinar as well, who can speak to some of those questions about worker safety, reopening probably.
Okay, I just want to put them out there for everyone. One is I am concerned about employees being required to wear masks and not customers. We know that masks are really more for protecting other people than it is for protecting yourself. And it just doesn't sit well with me that workers will be compelled to go back to work before the risk has really passed and be subjected to customers who don't have to show the same level of regard for their health and safety. And if their places of employment reopen, they're offered their jobs back, it's my understanding that whether or not they feel safe returning to work, if they decline that job, they will no longer qualify for unemployment. So I'm very uncomfortable with that scenario. And then I have a very, I'm wondering about industries like, let's say, housekeepers. They come to a house, there's no one home, they clean, they leave. Like, it would be helpful to get a sense of the risk involved in those kinds of interactions, because I know a lot of people who are just not working at all, especially self-employed individuals, because there's so little understanding still about how the virus has spread.
So this is Jennifer Vines, the Multnomah County Health Officer. I can take a stab at both of those questions. I can give you kind of a public health medical response on the face covering. So you're correct that it protects others around you by keeping your droplet secretions to yourself, that is to say inside your nose and mouth. There's also some decent science showing that a well-made face covering actually protects the wearer almost as well as some of the medical grade masks. And Multnomah County is working on some of the specifics around the types of fabrics and the types of designs that have been shown in labs to work really well. So there actually is, I think, more to be said about face coverings. I think, so as a general public health recommendation, I support the use of face coverings. I think what you're suggesting, Commissioner, is on a policy level and a worker protection level that I also support, but that raises questions around enforcement and exactly how that gets rolled out. So I will say that we share your concern about employees and about this very question of work sites being safe to return to, because we know that once things are open, then unemployment no longer becomes an option. To your housekeeping question, I would have to maybe think a little bit more about the potential risks. In general, we think of the virus as spreading through close and prolonged contact. If someone had been ill and had recently left the room and asked someone to come in and do a deep clean, would I recommend personal protective equipment for that person? Probably, because that would be similar to a hospital-based scenario where you're handling beddings and things that have been around someone who is sick and who may be shedding virus. So that may be an area where we want to flesh out some more public health guidance if it's not already been done by the state.
Okay, thank you for that. And do you know offhand, are workers expected to provide their own PPE, or will employers be required to do that? And if so, will they be given guidance on which masks are safe? I have a concern about people using cloth masks who have no idea how to handle them, that they need to be washed after every use. Yeah.
Yeah, so my best understanding is anything in the employment arena belongs to Oregon OSHA, the Occupational Safety and Health Association. And I know that the Oregon Health Authority, which is putting out sector guidance in consultation with the governor, is also talking to OSHA. And so that's where the requirements for employers are going to come down. And you're right that there is people who are not familiar with using masks or with personal protective equipment. There is definitely an education component for how to use it properly and how to clean it and how to make sure that you're not inadvertently touching your nose and face, messing with the mask, and actually putting yourself at higher risk from touching your nose with hands that may not have been washed. So I think there is more to do on this, but we share your concern around employee safety and want to get people back to work under the best possible circumstances.
Okay, thank you.
Mayor, I think you're muted.
Yeah, I knew that.
It's normally my job to tell them that.
Speaking of, Commissioner Hardesty, your question got answered, I take it?
I decided that I could ask my question after the last slide.
Okay, and why don't we go through that? I want to be respectful of everybody's time, and we're actually a little bit over time here. So why don't we finish the presentation? Commissioner Hardesty will have a question, and then I have one, I hope, quick question to end us off. And then at the end, I want to ask the chair if she has any closing thoughts. So why don't you go ahead and finish your presentation, please?
Great. So with all that, you may be wondering, as Kim described, the model of contact tracing and what's all entailed and testing, what is it going to cost? And so before you is an estimate, the reason it's an estimate is that we're trying to be the most efficient as we can and see if there are ways to leverage other funding and partnerships and whatnot. But so here's an estimate for contact tracing. It obviously has the personnel that we talked about, the expanding hiring of people, a budget for the wraparound isolation and support, the food, the assistance, the utility assistance, rent assistance, all of those things to make it possible for folks to be able to stay home and stay out of work for 2 weeks. That community health worker and community-based workforce, those trusted people, as well as you would expect, materials and supplies, regular office materials and supplies, as well as outreach materials, that sort of thing. Funding to work with community-based organizations to provide wraparound support and also to provide staffing. There's strategic field testing and internal services. And so once again, we think that that's between $25 and $35 million. And then there's actually one other slide. And it's just to say that there are other costs to reopening that we're figuring out exactly costing this out and trying to work through those partnerships and be as cost effective as possible. That community testing piece that Kim talked about, which includes us being able to have testing available across the county and also in partnerships with trusted community-based organizations so that we're testing in places that people already feel comfortable going to, that we're testing in places where they may be going to for other needs, although not at the exact same time. We're not going to be having sick folks in the same space as somebody picking up a food box or something of that nature. And then we're also thinking about what needs to be proactively in place to support our Black, Indigenous, and other people of color who we know are disproportionately impacted from the disease itself, but also the policies that we've put in place to stop the spread of disease. So those are our last slides. And I know we have some, I want to thank you all for your great questions, for your attentiveness to being excited to learn about what we love in our public health system.
Thank you, Rachel. Commissioner Hardesty.
Thank you, Mayor. Thank you, Rachel. Thank you, Dr. Vine, and all the speakers for what really is a very informative presentation. Mike, I want to echo what Commissioner Udaley said. I have real major concerns that based on some state actions that we have community members who will become more vulnerable and not less. The example for me is the restaurants that the retail operations that the governor says were never officially closed, even though we're all under a stay-at-home order. And so I'm concerned that we're not able to send a consistent message. I'm concerned that testing still is not available, especially for our most vulnerable communities. And I am concerned that the additional testing sites that have been set up assume that BIPOC, low-income people, houseless people have vehicles to be able to travel for treatment. And so I am grateful for all the incredible work that's done. So please don't take this as a criticism of Multnomah County. I know Dr. Vine now better than I've ever known her in my life because she's on just about every call I'm on. And so I greatly appreciate the work that you've done and kind of the outline that's been proposed. And I think you all share my concerns as well, because clearly you're leading with a racial justice lens. But for me, I am just a little anxious and nervous that we are setting people up for more severe outcomes, and we don't have the systems in place to support them. So I guess that wasn't a question, that was more of a statement. But let me ask the question that is the white elephant that's in the room, which is, I see your budget, your anticipated budget. And so what is Multnomah County investing in that budget? And what is your ask of the city council?
So just in fairness, Commissioner Hardesty, I told them that we would not pressure them on specifics around a budget ask today. They're certainly able to talk about, they're able to answer that, but I just want to be clear that I had told them that they could provide us context to help us set the stage for our Tuesday work session, which is on the distribution of CARES dollars. And I think they were planning on playing a more active role between now and then on that.
I appreciate that, Mayor. Let me just say that the mayor didn't tell me that he had that agreement. So I knew that was...
They're absolutely able to answer the question. I just wanted you to know that I'd had that conversation with you.
I appreciate that. Thank you.
I just say to thank you, Commissioner, for your relentless pursuit of justice and asking the questions about equity. And I just want to say I share your concerns. And, you know, we're going to continue to get a lot of pressure to open up, and we've set a higher bar. And so all of the support in the city of Portland is helpful as that increasing pressure comes. And that is exactly why we're charting a different path and saying we have to have these things in place before we open up. It's too late to be thinking about them after the fact once people are being disproportionately impacted. So many thanks.
Thank you also. Appreciate that.
So, and Commissioner Hardesty, the slide previous was, I think, fairly targeted on the contact tracing budget. And I think one should assume that the county is looking to us for support on those particular items that are required under phase 1 reopening. And so I know that the chair will have many conversations with us about her hopes. I have a call later this afternoon with some of the East County jurisdictions that are not specifically getting money through the state. I know they have some concerns about reimbursable costs associated with their COVID response. So there's lots of conversations to be had there, and I appreciate your raising the question.
Thank you, Mayor. And I also put on the table, we still don't know what will be reimbursed by FEMA as direct costs to address this pandemic. And so you're right. I think all these questions are important to have on the table and be transparent about.
Absolutely. Commissioner Fritz, you have your hand raised.
Thank you, Mayor, and thank you everybody for the presentation. I know we're over time, so maybe this question can be answered later, but it's building on my colleague's concern about employees being required to go back to work, perhaps in unsafe situations, but in particular, it seems like the governor's direction and the counties is that some businesses can open if they have the protective devices, etc. How do both employers and employees prove that they don't have those things? The concern I've had from salon workers is that they don't feel that even that they can safely provide services, but on the other hand, they're very worried about losing their unemployment.
Thanks, Commissioner. This is Jennifer Vines, Multnomah County Health Officer, for those who are just listening. I am not an expert in employment or labor law. My best understanding is that sector guidance would be published by the state, potentially refined or clarified at the county level. And then any specific worker complaints would go again through OSHA, the Oregon Occupational Safety and Health Administration, which would be sort of the focal point for any kind of follow-up or specific action on the employer. I guess I will just be very clear that Multnomah County does not have the capacity to review reopening plans for all of the businesses in our counties. At least our public health arm is not focused that way. So there is a level of trust here with employers around doing the right thing, around following sector guidance. And then I suspect it will be a complaint-based enforcement. And if others know differently, please chime in.
Well, thank you. That's helpful. If in your advocacy with the state, it seems like complaining to OSHA is after the fact, and I think that some people, some of the workers, as well as the people who may or may not be patronizing the businesses, are just not feeling safe to go back into work. And it seems like there should be a mechanism to prove that, particularly for people who either are in vulnerable communities or live with people who are vulnerable, that asking them to go back to work or else lose their unemployment. Just please, in your advocacy with the state, continue to ask them to have some kind of an exception process that's clear and not whether it goes through BOLI or OSHA or the health authority or somebody. Thank you.
Thank you, Commissioner Fritz. And Dr. Vines, I have a related question, but it's from the different side of the spectrum. I've been getting calls from business owners and in particular, I'd say building owners, landlords, who are noting that we are not requiring masks. And they are wondering if they are exposed to any liability in the event that somebody comes into a business without a mask, or alternatively, at any rate, somebody comes into a business, they don't have a mask on, and it later turns out that an individual with COVID came into a business and exposes either other people or employees in that business to COVID. Are the businesses exempted from liability because they followed the state guidance that does not require masks? Or does it require them instead to require masks in their place of business, even though the state guidance, the health guidance, does not require that? Has there been any clarification on that point?
Thanks, Mayor. I think this is a question for a lawyer, probably. I would say that the state sector guidance is setting the minimum expectations for employers. I think employers have the discretion to go above and beyond. Again, it came up before just as a question of policy around face coverings and enforcement and what that exactly looks like. I don't have a particular opinion except to say from a public health standpoint, I think face coverings are helpful, and generally people should be wearing them in public, and in particular in indoor spaces.
All right, because we're under some pressure. I wouldn't describe it as withering pressure, but we are under some pressure to pass a requirement that inside facilities people be required to wear masks because people are concerned about this liability issue. And so it's putting us in a bit of a squeeze between the public health guidance, which doesn't require it based on a public health mandate, but on the other hand, the world is full of attorneys. So
Mayor, to that point, I just heard that our hospitals and assisted living facilities are asking the governor for exemption against liability as well. So this is going to be a much bigger question about who's liable if somebody catches COVID-19 because of what the state, city, or county did or didn't do.
Yeah, so to stay tuned for that. I'm sure we'll all be in that one together. Last but not least, I want to turn this over to Chair Kafoury to wrap this up if she would like. And Chair, before I forget, I want to invite you or a representative to be at our Tuesday work session at 9:30 a.m. That's the work session where the council is going to start discussing the distribution of CARES dollars. I know that close collaboration between the city and the county is absolutely necessary here. And so I want to make sure I extend that invitation to either you or somebody from your team to participate in that work session. But I want to give you the last word this morning. I want to thank you, and I want to appreciate your public health and your emergency response teams. And I'll just quickly share a 30-second story. When I started as Multnomah County Chair, which was 13 years ago, believe it or not, in my very first meeting with the then health officer, Lillian Shirley, I asked her what the most important thing I should know about public health was, since I knew exactly nothing about public health. And I said, "What really concerns you?" And she said that what kept her up at night was the possibility of a global pandemic. And I remember just sort of thinking, of all things you could think of, this is it. And here we are 13 years later in the midst of a global pandemic. So I just wanted you to know I was thinking on that admonition a lot in the last several months for Multnomah County. Chair Kafoury, you get the last word.
Well, thank you, Mayor. Thank you to all the city councilors for having us here today. And I really appreciate the partnership that we've had in good times, but this pandemic has also shown the strength of our partnership together. As we've been saying, we're all in it together. So we need each other to get through this. And I also want to appreciate my team. I think anybody watching this today really gets a flavor of how exceptional the public health department is at Multnomah County. And just the questions, the important questions that you all have raised here today just shows the complexity that we're going through. Not only is this team working to save people's lives every day, they are also working to develop the policies and the strategies that are going to help us in the middle of this pandemic. So they're actually building the plane and flying it at the same time. So I want to give this team a shout out, and I can't thank them enough. I try to thank them every day because they're doing such a fantastic job. And again, the questions that you raised today we don't have all of the answers yet. We're still working on this and we need your input. So I appreciate that this is the beginning or the middle of our conversations, and we will continue to have them as we work through this, because to mask or not to mask, how do we help businesses get prepared? How do we help workers get prepared? These are still outstanding questions that need to be looked into before we get ready to push the green go button. So look forward to talking more about the financial aspect of this. I will also just give a kind of a broad overview that we have identified that the public health contact tracing, the testing, the stuff that we went through today, in addition to the sheltering that we're doing for our unhoused neighbors, we've anticipated that we're going to spend through Multnomah County about $75 million over the next fiscal year. And of those dollars, we have about 30 million identified. So we're well on our way, but we're not there yet. And we will have more specifics to talk with you about probably later today as we continue to refine those numbers, and also developing partnerships like Commissioner Hardesty talked about with Portland Fire will help us reduce those costs. So there's always any other suggestions you have like that are most welcome. Thank you again.
Very good. And this is, of course, not the end of the conversation. It's the beginning, as the chair said. We greatly appreciate the partnership and the leadership of each and every one of you. So thank you. Thanks everybody for sticking around a little extra this morning. Have a fantastic day. We are adjourned.